Thank you, Ken, and he worked through those drums as well. We really appreciate the fact that he didn't hesitate, he kept going, so thank you very much. Next, we're going to have a panel, and I want to invite up Briana Duffy, Sarah Arnquist, and I don't have the other paper. Jennifer Black and Victoria Tokarski. One of the things that we've been thinking about over the last few years, as you know, we've been really focusing on crisis services as making a difference. But part of the problem is that crisis services really evolved from the public sector, using almost all general state funds with some block grant dollars. So part of our challenge has been, how do we engage more the private sector? And that's what the panel is going to talk about and tell us how to do it. Thank you.
Good morning, everyone. We have the esteemed position of speaking last before the break, so there's been a lot of good information this morning, and we really appreciate you hanging in with us as we head towards that morning break. I'm Jennifer Black. I am Vice President of Business Development with Beacon Health Options. We're very happy to be here. This is our first time at this conference, and there's been a tremendous amount of information sharing, and it's been terrific. Actually, can I have that little, that thing? That's okay. And as Brian mentioned, we're going to talk about comprehensive crisis services from a public health perspective. There's been a lot of talk about crisis services over the past several days, and so we're not really going to talk about why we need it. I think we can all agree on that. And so it's really thinking through how you get there, right? What are the steps you need to take? How do you evaluate what's in place? What problems are you trying to solve for? What are the steps towards transformation? Who do you need to engage to get there? How do you get them to the table? What stakeholders do you need? And so really that's where we want to focus today on our talk. So just a little bit about Beacon for those of you who may not know us. We are the largest specialty behavioral health management organization in the United States. We serve over 37 million members across the country in all different sectors. So we work with the federal government, we work with state and local governments, we work with commercial health plans and with large employers as well. And we have over 30 years experience working in public sector markets, as you can see on the map here, and including crisis services. And where we really wanted to focus today was on a few examples of where we're providing crisis services. David Covington talked about the Georgia Crisis and Access Line. I believe that was yesterday and maybe probably earlier this week. So we're going to focus our time today speaking on our services in Washington State, where we manage crisis services for 8 counties in Washington, and also in Massachusetts, where we manage a statewide emergency services program. So I'm going to invite my colleague, Sarah Arnquist, up to talk about Washington State. She's our Vice President of Client Partnerships in the West and oversees our contracts in Washington State.
Great, thank you. So you all know that there's myriad factors impacting the need for crisis, and a comprehensive crisis system really should be designed to respond to sort of all of these constituencies and all of these agendas, and so it really impacts the entire public, multi-sectors, and I'm just going to take this as a given that everyone is sort of here, and then as we move through the next slide, so today we have emergency response systems for physical health, where you've got urgent care and emergency rooms. People go there, they get the services they need. Both public and private payers pay for those services. It's a given. On the behavioral health side, typically what we have is law enforcement may be called, first responders and ambulances, and then also hospitals in the emergency room. So an individual will go there and get services. Public and private payers may pay for those, but if you build out alternatives to those, largely that is paid for by the public system today in most communities. There are exceptions, and we'll talk a little bit about Massachusetts later. But how do you start beginning and putting in the building blocks to have a more diverse array of public and private payers into the system? So that's where we're going to now focus as we go toward talking about Washington. But as you all are as policymakers and trying to think through where to begin and how to start with crisis, we put up some questions that we thought are important. So do you want a statewide or a regional system? Do you want a single administrator of crisis services or multiple payers and administrators for crisis services? How do you bring the commercial funding, payers, and different systems into that full continuum? And what are the essential components of the intended crisis system that you want? How will data and communication support resolution and warm handoffs? And how would you measure progress, define success, and ensure accountability? The first speaker this morning talked about needing a vision, right, for the system, and I think this is where it starts, is thinking through these questions as you set out in designing what that crisis system will look like. So it's important to remember that crisis systems don't naturally exist. Right, so like emergency response systems, they include multi-sectors, different players and different needs, and they must be built from the ground up and continuously worked at. It takes significant effort and ongoing effort. It doesn't just start, and you have to practice at it, right? So like if there's going to be an earthquake, you have to be ready, and everyone has to know their role in that system and know the handoffs that occur. And so we think in order to get to that vision, that we have this framework that we use as we look through the different components and phases in a community. Most communities tend to focus on phase 3 and phase 4, which are acute interventions and crisis treatment. But if we're not looking upstream at prevention and early intervention, and then at the end of the recovery and intervention or integration, people are just going to cycle through phases 3 and phase 4. So as you think about crisis services, it needs to include that full continuum, and investments need to be made along the way. And then there are components into a crisis system that we think are key. So here's 8 key components. A single front entryway, a 1-800 number that then dispatches and sort of knows where all the parts are in the system. Mobile crisis units, community-based locations, system oversight and management, 23-hour receiving centers or peer living rooms, providers for all levels of care, and integrated SUD and MAT, and crisis collaboratives. So that's a lot, right? So where do you begin? Like, there's a lot of paralysis and thinking like, okay, we don't have any of that, or we have some of that, and how do we get started? So that's why I want to talk about the story from Washington. So Washington State has dramatically transformed its behavioral health system in the last 5 years. And the way that it's organized is carving all of the Medicaid, mental health, and substance use services into the managed care plans. But in doing that, they realized that crisis services needed to exist in the community for anybody, regardless of payer. Right? You could be the richest person in the community or the poorest, and if you're in a psychiatric break or you're in an acute episode, you need a crisis system. And so rather than sort of split the responsibility for crisis services out across 5 different payers, in some cases, they centralize that into one entity that they call the Behavioral Health Administrative Service Organization. And that one entity is responsible for purchasing and organizing the crisis system on behalf of all the Medicaid managed care plans in that region, and hopefully on behalf of other payers in that region too. And so Beacon is that behavioral health administrative organization in 3 regions, which is about 8 counties in the state of Washington. That ranges from Pierce County, which is largely urban with Tacoma, and then very rural areas like Skamania County, which is basically a forest. And so, needing to develop crisis response systems for an urban environment and then also for a rural environment. So in this massive system transformation, thinking through where do you begin? So we decided that on day 1, the Washington actually told us one thing on day 1 needed was a 1-800 number. There were all 1-800 numbers in the regions, but to varying degrees, they were the entry point. And so we said we wanted to, really promote that 1-800 number to be the single entry point for crisis services in the community, and then to building out these components. Not all the components existed on day one, not all the components exist now, but we spent a lot of time listening to the communities about what was most important to them, where do they want to prioritize, and then we created action plans. And these action plans had achievable goals that we could then show that we're making progress to build momentum and get people to come back to the table and to continue to participate. That we found is really crucial, so people need to feel like there's actually something happening and not that people are just coming to a meeting to meet, right? But that everyone's coming to that meeting with action items and goals and then bringing back and showing progress. So that was pretty key to where we began and where we're going. And then we formed crisis collaboratives in each community that are multi-sector: police, law enforcement, judges, the mobile crisis teams, the crisis hotline, et cetera. And they meet monthly to sort of work through this action plan and to set continuous progress. One key thing is to establish protocols, or to write down what people do. So there's a lot of assumptions, or people, they're supposed to be doing that, or they're supposed to be doing that, but it's not documented. And if you don't have something documented, you can't hold someone accountable. And so what we did was, we documented exactly what everybody's role in the crisis continuum was, made sure that everybody signed off on that, and then the agencies can hold each other accountable, right? So, if the mental health agencies during the day are the ones who are supposed to respond to crisis services, but they're not, they're calling the mobile crisis team in instead, we can go back to a document and say, you all agreed that this was what you're gonna do, and now talk through that. So it seems simple, and it doesn't cost any money, but it actually was a sort of a leap forward for the systems. And then building capacity. So we convinced all the managed care organizations to expand mobile crisis because it would keep their youth in particular out of emergency rooms. We have seen decreases in youth in emergency rooms because previously that was the only place to go. And so the managed care organizations are continuing to invest in the crisis system because they see diversion options from hospitalizations. Additionally, in our contracts, we're requiring peers to be part of the two-person response in crisis. And so we actually give incentives to the organizations that are doing the mobile crisis to hit certain benchmark targets for how much a peer is that second person response. We're requiring follow-up in the crisis system. And then we've given micro grants to create to find new pathways and new earlier interventions through domestic violence shelters and schools, et cetera. Creating new relationships and partnerships. So 911 dispatch is now patching into the crisis line. So they agreed on sort of a set of questions that if I called 911, the 911 dispatch could say, oh, this isn't actually, a medical or a law enforcement emergency. I'm going to patch you over to a professional counselor who can help you with that. We've seen the call numbers double from 911 into the mobile crisis or the crisis line, and the demands on law enforcement have decreased, not entirely by any means, but to some degree. We're also working on building competency within all organizations to sort of support crisis. So working with partnerships at universities to try new tools, to give training so that the knee-jerk response isn't to immediately call the mobile crisis team, but to address that crisis there. So there's an expectation in the community that everybody's job is to try to provide relief to this crisis, not just to assess and hand off to the next level. So I think there's still lots of progress to be made, lots of work to be done. Moving towards statewide standards is where we recommend that things should go, so that there is, the crisis response in one community is not vastly different than the crisis response in another community. Having better data to track outcomes. So as I said, I'm a challenge with Washington's transformation is that the data is now split across many more organizations, and so compiling that data to see where, truly what our impact is has been more difficult. And now we're really focused also on being able to build a private sector and commercial entities for these services. So one area where we're starting is around first episode psychosis. So we've given grants out, federal block grants out to providers for first episode psychosis response and to build wraparound team-based care models, but they have an obligation to go and build private payers if somebody has private insurance before they can come and seek additional reimbursement. So that's written into their contracts, and the goal is that eventually they will get established relationship with private payers for all of those reimbursable first episode psychosis. The next step is then for the acute diversion, right? So the crisis stabilization, the 23-hour, to help support contracts between the providers and the private payers and provide the technical assistance to make that happen. So that's where we see a lot of kids in particular who end up in mobile youth crisis because the school calls. The school is not checking what their insurance is before they call. And so being able to have that mobile crisis teams be able to get private reimbursement. And so for that, we're looking to the experience in Massachusetts, where Briana is going to talk, where the system has been in place a lot longer and is a little bit more mature and is today including the commercial insurance in its system.
Good morning, folks. My name is Briana Duffy. I serve as Beacon's Chief Partnership Officer, and I'm our General Manager of Crisis Services. So very happy to be here today. As Sarah said, not telling me how to use this clicker here, she did say that I'd be talking to you a little bit about Massachusetts. So we've had the really good fortune of helping to participate in the delivery of crisis services in the Commonwealth for over 20 years. So Sarah talked a little bit about some of the early work that we're doing in Washington. Massachusetts is a little bit older, sort of like the difference between Sarah and I. So thinking about how we get public and private payers to the table really is a conversation about sort of stick and carrot, right? I think some of what we can consider as policymakers is we can issue mandates. We can simply say that we've been talking about parity a whole lot in the past couple of years, but we haven't really been talking about crisis services. It's a little bit of a miss. We kind of talk about that internally, like we talk about parity all the time, about having the equivalent behavioral health services on par with those services available to medical, but we miss crisis. And I'm not sure sort of how we kind of got there, but we did miss some of those critical crisis components. So with that being said, because we don't have a mandate, it's all about making crisis services something that commercial payers want to purchase. And so how do you really design a crisis system that has those outcomes and gets people to the table voluntarily? So we've spent a fair amount of time and effort in Massachusetts thinking about how do you use the carrot instead of the stick and getting folks involved with the whole crisis continuum. There are many people I'm looking in the room who know more about the Massachusetts system and have certainly dabbled in it. And what Sarah said, I think, is really the take-home message here is that crisis service systems are not something that are static. They've got to be something that are evolving at all times. And so while we've been at it for 20 years, the last major redesign and overhaul was actually back in 2009, and we're about to embark on another redesign right now. So 10 years later, we know that what we've been doing actually needs additional attention. And some of those questions is how do we know that? We ask the people that we serve first and foremost, and so they're really helpful in giving us feedback about what's helpful and what's not as helpful. We recently procured NAMI to help us participate in an evaluation of our system, really interacting with folks who have been recipients of the crisis system, their family members, and treaters involved in that process. And they're really clear that we've got some opportunities. And so some of those opportunities include the fact that Massachusetts is on a top 10 list. Unfortunately, it's not a popular top 10 list because it's the top 10 list of opioid prevalence in the United States. And one of the things that we know is that we need to be able to be more responsive to the fact that we have an opioid problem in Massachusetts, and our emergency service programs have to include being able to find a solution of that. Why is that really important, particularly as we think about the context of crisis services and the evolution of really having commercial payers at the table? as we all know about addiction, is that is not something that necessarily is focusing on what type of insurance you have. And if there has not been something that has forced everybody to the table in a differential way, the opioid epidemic in Massachusetts certainly is. Unintended consequence, right? Not why we want people to be engaged in dialogue, but the good news is people are engaged in dialogue. So going a little bit more to where things are in Massachusetts and going back to the design that was put in place in 2009, we often hear from our colleagues, I think everyone in the room, and when we're talking about crisis and some best practices, we know there are core components of a crisis system that help make a difference. So we know that having some of that centralized intake and being able to help identify how to help do that sort of traffic control, as we hear David Covington talk about a lot, and helping to direct people to needed care, we know that that's definitely something that we believe in as well, and we've been working at that for the past 10 years. That being said, we did something that we thought was fancy, and I'm not so sure that it achieved the best outcome. And that is, we have a system where you dial 1-800 number, ability to go out and market it, and you automatically get dispatched to one of 21 community-based locations. So the Massachusetts system, when you think of Massachusetts as a state, we're certainly not the biggest state, but we devised this system back in 2009 to have 21 components. And the idea of those 21 components is that there can be a response time for mobile crisis within no more than an hour's time, no matter where you sit across the Commonwealth. That's a good thing because we're able to provide care at a more localized level. It's not a good thing because we don't always know what's happening across those 21 continuums until after they've happened. And so being able to bring some more real-time experience into that conversation is certainly helpful. But we have a community-based location, so we have an alternative to people going to EDs. Whether or not people are using that as much as we'd like them to, I think, is part of the conversation. Mobile crisis for youth. So Massachusetts did use a little bit more of the stick recently, and so there has been a mandate for commercial carriers to provide a core number of additional services to Medicaid youth, and that includes mobile crisis. So a little bit of a stick piece of action happening there, but it's a very effective service. We know that if there is a crisis for someone and they are seen in the community and served by one of our mobile crisis teams versus they are seen in the ED, if they are seen in the ED, they are 50% more likely to be hospitalized. So there is like sort of a no-brainer when it comes to do not pass go, do not collect $200. That's just sort of the way things seem to be working for us. We have the ability to do some follow-up. We do some peer partners, as Sarah was talking about, in the way that services are deployed for our youth. And so some of those peer partners are actually for families and helping them to understand how to navigate the system. On the adult side, we don't have as long as a follow-up process available to folks, so we're looking at helping to expand that. We also have a web-based search tool that talks about all the levels of care that are available across the Commonwealth by zip code. So again, you go in and we've got this glossary. And I will tell you that you have to have a little time if you are not well-versed in the crisis system or in the system of care, and you are trying to find a service. And the reason for that is we have over 40 levels of care in Massachusetts, which is great. But if you are a layperson, sort of as evidenced by this more recent NAMI survey that we conducted, people don't know about the array of behavioral health services unless you're a behavioral health geek like all of us sitting in this room. But the layperson usually knows that there's outpatient, inpatient services and not quite sure what happens in between. So it's a little overwhelming when we think of self-service. I think we want to promote that to the extent that we can, but it requires us to also do a fair amount of education and training. So my point being, we've got a pretty well-established crisis system, and those are certainly critical components. But again, going back to Sarah, we don't think of crisis in isolation. We think of crisis as a continuum across that entire system that we provide. And really the best crisis is no crisis at all. And so how do you avoid those crises before that they're happening? How do you make sure that if there is an experience and someone does begin to have a higher need than anticipated, how do we proactively address that? There is a very core number of individuals for whom are well known to the behavioral health system. We certainly can help anticipate that there may be a crisis, and we can think about how we do some proactive planning when people have the ability to give thought to what would be potentially most helpful to them. We've done that in some really good pockets, and we've got some more work to do. That being said, okay, so where are we going to go from here? We are talking about having an introduction of a comprehensive behavioral health clinic, so CCBHCs, one-stop shopping, rapid access, don't have to wait for services. We know that when people have to wait for services, there is a likely exacerbation that occurs, and so it's equally true if they're not receiving the right services. So how do you really drive a system of behavioral health care focused on quality to ensure that when people need access to care, the access to that care is being done in the most proficient fashion that we can possibly provide, that we can instill that hope? It is really disheartening for someone to go and seek treatment and not feel that relief when they need it. And so what we don't want to do is we don't want to be hope busters. And I think, Dr. Minkoff, you spoke of that really well, that there's a lot of different components to what we need to be providing when we're talking about outcomes and quality. We talked a little bit about the fact that the system's available to everyone. And so we're about to deploy an application to participate in an ET3 program. This is really designed to help bring additional resources through the use of paramedicine into the community to serve our Medicare populations. What we know is that older adults are served by this system today, but that they also really benefit from having home-based care whenever it's available, and that they're able to receive whatever those co-occurring and some of those complexities and getting that remediation for that entire presentation. And so being able to really triage, treat, and transport, not to EDs, but to community-based locations, is a little bit of a work in progress that we're working on. Talked a little bit about the stakeholder listening sessions and about how we're going to continue to move things forward. Lots happening, as I said. We are certainly trying to figure out what we're going to do about our opioid epidemic. One of the enhancements to our website where you're able to go and find access to care included the addition of medication-assisted treatment providers, so you can see in any real time where there's a provider who's available to have you go in and immediately begin your induction if that's what needs to occur. So what does this all mean when it comes to bringing commercial players to the table? It means that today we've got about 20% of our commercial insurers and Medicare insurers participating in our emergency service programs. That's really good, right? I think 20% is probably one of the best numbers that we've seen nationally. Unfortunately, it's not high enough in our opinion, and not all of the payers in the commercial space in Massachusetts today are participating. Beacon has the good fortune of partnering with a lot of our health plans on multi-sector sides, and so health plans in Massachusetts typically are serving multiple lines of business. The partners that we have all access crisis services regardless of whether or not you have commercial coverage, whether you're part of the exchange or others. We've been able to spread that good wealth as well as to a couple of our additional health plan partners in the region. But you see there's also been a little bit of a dip. So if you look at 16 and into 17 and 18 around the number of encounters that have been paid for by the commercial population, you'd say, well, what's happening? It doesn't look like this is working as well as it should. And this is about that larger continuum of care and really looking at crisis not in isolation. And that's really when we started to see the spike of our opioid epidemic. And so what's actually happening is that more people are overdosing and ending up in the ED instead of being able to have interventions in the community. So commensurate to it equates to just under a 1% dip. There's been a 2% increase in the number of folks seen in the ED, and there's almost a 100% correlation to that being about opioids. So more work to be done. So key takeaways in our last couple of minutes here. Crisis is not just about the behavioral health system. I didn't talk too much about the role of crisis collaboratives, but we really work at a local community by community level as part of our work in driving that quality, because we do perform additional services across that broad continuum. Providers of all levels of care in any given region get together on a routine basis to do exactly some of those things that Sarah talked about, and including those continuums and making sure that there are warm handoffs and that people know how to access one another. Services have to be localized. We've got to figure out a little bit better about how to get that information about who's in the air at real time. Consumer-centric, pan-player agnostic. What we know is that when people need access to behavioral health care, they should have it regardless of the type of insurance that they have, and crisis services will play a critical role as part of that. Crisis collaboratives bring voices to the table. We did take a little bit of a borrow from our friends in Canada and something called the Chelsea Hub model for us. It really started in Saskatchewan, but it includes the police, it includes all the behavioral health providers, it's local entities, and they do some real proactive planning when it comes to avoiding crisis. So talking about how they get out and do some door knocking in advance of crisis happening, and that's actually been a model that's been replicated across 8 other communities in Massachusetts and will continue to grow. Incredibly, incredibly effective. And then, emphasizing treatment access and health outcomes. It's got to be about the quality. It's not just about the services. It's going back to that carrot and actually providing services that people want to buy. And that includes, being attractive to payers, but even more importantly, being able to be providing services that are attractive to people consuming our services. And so last but not least, we're going to go back to that comment that we started with about parity and really thinking about whether or not crisis services needs to be on par when we're talking about essential benefits and what's included in a parity package. So with that, I did not allow, I think, more than 8 seconds for questions. Got a couple minutes left, but that's the end of our presentation, and happy to have some questions if folks would like them. No questions.
Actually, can I make
Excellent.
one shameless plug?
Yeah. One shameless plug. Come on.
One shameless plug in our last couple seconds here. So, obviously, there's a lot of work still to be done, and we all haven't figured this out. And so, the shameless plug is we have a booth on next door, and we'll be moving it to the Madison for tomorrow for those of you still around. So please come and chat with us. We'd love to hear from you, hear what's happening in your state. Have some cross dialogue about how we might help each other, because I think that's the only way that's going to get us there, right? It's an open dialogue about what others are doing and how it might work, because in every place we look quite different because it's based on the needs of the populations we're serving and based on the location in the state or the locality. So it's always helpful to hear what others are doing because people are trying to solve similar problems in other places. And it looks like there might be a question, so I don't know.
Yeah, well, thanks for a really comprehensive presentation. I guess I'm trying to integrate this with what Ken Minkoff was saying earlier. Glad you're standing next to him. And I guess the question is, given the involvement of private payers and people like homeless folks who aren't connected and usually don't have private care, is your crisis system integrated? In other words, is there no wrong door, or do you still say, well, no, you're a county issue and we can't deal with you?
No wrong door for sure. So I do think I talked a little bit about some of the continuous quality improvement that we'd like to apply, and some of that includes expanded hours for our mobile crisis team. So we do have limited hours on our adult side, which is just not helpful. But when it comes to serving individuals who are homeless, absolutely. Sarah talked about how not only do we support evidence-based practice, but we also support practice-based evidence. And to that end, we are doing a pilot right now, actually, with an organization called Healthcare for the Homeless. They have a mobile pilot, they have a mobile van, and right now what they're doing as part of the initiative that we're working on together is they're working collaboratively with the individuals who are tracking what's happening on the opioid side of life. And so using some of those opioid overdose heat maps and understanding where people are actually using across the community. And we're sending the mobile van out. What we're doing is we're actually adding in some additional behavioral health capability. And the Healthcare for the Homeless team works very closely with our emergency service team in that area to make sure that there are warm handoffs. And I mean, those are only two folks in that whole continuum, but definitely a component.
Okay. Can I make a comment since we're being integrated? So one thing I just want to say, you guys were talking about standards. Margie Balfour and I are on a committee for the Group for the Advancement of Psychiatry, which is in the U.S. that some of you know about. And we are just putting out, in other words, we sent out a pre-release draft, and we're going to issue a regular draft early next year of standards for designing an ideal behavioral health crisis system for any community. It's about 150 pages, and it's very well designed for policy nerds. The wonderful thing is, I don't know these guys, but everything they said was stuff that's in our document, and they have really cool slides that I want to steal. And the other thing is that around the opioid epidemic is what's happening in a lot of crisis services, and Margie can talk to this, is providing instant access to initiation of medication-assisted treatment in the ER for people who are in need. And because there's no possibility that these folks will last to any kind of handoff, even if it's the next day.
And that is an initiative that's happening in Mass right now as well. So all EDs have to have induction capability.
So for Washington State, and there are people from Washington State here, and so they can speak to this more in depth as well. But Washington State, for the involuntary assessment process, they have transitioned a position to a designated crisis responder. So it used to have a different name because it was very focused on the mental health component only. Now that designated crisis responder must have the capacity and training for both substance use and mental health. So that's one way the state has moved toward integration and requiring it at the crisis responder level. The second component is the state is, as it is, dissolving some of its state hospitals and pushing people out and really focusing on building more options in the community, has, I think, probably read the Beyond Beds papers and has embraced that to the extent it can, but is investing in crisis stabilization and crisis residential, and wherever possible, having that integrated with, so you could go and you could do acute withdrawal, move into the crisis, residential, whether it be for substance use or mental health. And we're working with providers who are, really requiring the capability on both sides in order to stand up those facilities. One last thing that I'll say about Washington is that I think, these grand public policy experiments, we'll see in 5 or 10 years sort of what it comes out from it. But the idea to have an organizing entity or a purchasing entity that is just focused on crisis really has injected an incredible amount of attention and focus and momentum to get things done, right? So we're not distracted by a lot of other things that are really important in the system and continuum as well. We are really just focused on that crisis continuum. And in order for us to stay relevant, we have to demonstrate progress. And so, we're bringing sort of our full force with us to really work on crisis services. And, in Washington, I think it's kind of a brilliant public policy move to really expand out that continuum.
Okay. Thank you very much.